Well, it's great to be here. I guess we're going to discuss a situation in which we hope to never find ourselves, but we might, so let's talk about how to be ready for that. Before I get going, I have to disclose my conflicts. I don't have any monetary conflicts, but I do have this problem with the Saul Snyder meeting that whenever my son's involved with a big basketball game, I'm speaking up here. 3 or 4 years ago, he was in the NCAA tournament for the Division III, and while I was up speaking, and today his team, he's coaching now at Eastern Washington, and they were playing Weber State to get into the playoffs. I hope this talk goes better than his game did. All right, so the objectives of today's talk is to develop a plan for the optimal management of vascular access during obstetric emergencies. And what it's really going to come down to, I think the new knowledge that you're going to get is learning about intraosseous access, and also hopefully I'll show you how to use ultrasound to start a peripheral IV. Both of these are really simple techniques to learn, no big deal, but they should be in your bag of tricks when you have an emergency. And the other thing, the most important thing, as with everything in anesthesia, is that it's all about preparation and being prepared when the time comes that you can use it. If you're not prepared, if you don't have these, if you haven't practiced these tools, if you don't have them available, they aren't of much use. So we're going to have two scenarios. We're not going to, that we're going to discuss. One is the stat C-section for the prolapse cord. The woman has no IV, and she's been recently hospitalized for a seizure disorder, and they used Dilantin and everything else in her veins, and her veins are completely shot, and she just does no peripheral veins that you can really have great access to. The other one is a woman who's having her third baby. She has a known placenta previa. She's had 2 prior sections. At home, she bled a lot, but when she comes in, she's hemodynamically stable. It's not a huge rush to get going, but they want to get going as soon as possible. And she doesn't have any visible veins, and she's extremely claustrophobic. So these are the 2 scenarios we're going to discuss, and let's start with the first one. And so that's stat C-section for the prolapse cord. They are really in a rush to go. And lots of chaos going on, and now you're really not concerned about hemorrhage at this point. What you're really interested in is getting access enough to get this woman to sleep so they can get the baby out as soon as possible. And when you look at this woman, you just really don't see any IVs. So let's have a show of hands here as to what option you're going to take. These are the different options available. And let's mask induction with IM sucks, and then look for a peripheral vein, and, because you are better than anyone else, so you're going to find that vein. Ultrasound for a peripheral vein, actually starting a central line, or else go for intraosseous access. So let's start with the mask induction and IM sucks. Anybody in the room going to go there? Not even Sheila. Okay. All right. All right, how about looking for the peripheral vein? You're going to find it. Nobody else has found it. You're going to start there and go on. So you're going to try before you do anything else. Okay. All right, we got a few hands tentatively going up. How about ultrasound for a peripheral vein? Okay. All right, how about going for central access right away? You're going to go for that. How about intraosseous access? All right. Not many people. All right. Now, of the people who held up your hands, how many are pediatric anesthesiologists also? Anybody a pediatric anesthesiologist here? Would you use intraosseous access? Okay. All right. Well, okay, we're going to talk about this. This is what I think now that I've seen it and studied it a little bit, I'm a lot more convinced about it. I've talked to our pediatric anesthesiologists, and they just swear by it. Well, some of them swear by it as, boy, when you're having a difficult case, just go right to this. It's really easy. It's really simple and very effective. And it's interesting. That's the younger guys. The older guys, well, I always get the IV, or I always find some other way. They don't use it. But I think it is a great tool. I think it's really underutilized. It's really easy. It's really fast, highly successful, versatile, and it's really not that painful to insert in an awake patient. I mean, when you think about where you're inserting it into the bone, you think, God, that's got to hurt when they drill that into the bone or you dig it into the bone. But it's not that bad. So in order to learn about it, the first thing is, on the bottom here, there's this excellent review article that's coming out in anesthesiology. I've got some of the pictures from that article. They're just beautiful pictures. They're going to be a part of the presentation. And I really recommend that you read that article. And it's got great information about it, too. And then, more importantly, we're going to watch this video first to see how they do the intraosseous catheters. And this video is like, I don't know if you've read the accounts of August Beer doing the first spinal anesthetic, where he and his assistant, did it to each other, and then they tested each other with, hitting their legs with a hammer, and to see, oh yeah, it really works. And then they drank brandy and smoked cigars afterwards, and then we're in bed for about the next week with raging spinal headaches. Well, these guys in this video are carrying on the tradition of August Beer and his colleagues. This is just an amazing video. We're going to take a little time to watch it. And here they are putting in these intraosseous catheters. And a little gruesome looking, but yeah.
What?
Yeah, that's definitely a tube.
All right, now we're going to aspirate.
I can't feel you aspirating.
Isn't that beautiful? Oh, it's coming out so easy, the blood is.
And I can tell you that the insertion was like next to nothing.
Really?
Absolutely next to nothing.
Wow. It was fast. It was doing it
It
really,
really
easy.
fast.
It was shockingly easy.
I've had IVs that hurt worse. I mean,
So, he's wearing the white coat for just a little credibility here, but you know that if you had a wide-angle lens here, there'd be like a keg in the corner. It's like,
yeah, it's a totally zero. It's totally flat. It's good and stable. I feel absolutely nothing around it.
Okay. Okay, we're going to use a technique of holding the leg, pulling gently upward while we twist clockwise.
remember, lefty-loosey, righty-tighty.
Not a single thing.
You see, people are worried about how bad it's going to leak and bleed after you take it out.
Not,
IVs do worse than that.
oh, yeah.
15 gauge IV, can you imagine? It would be pouring out.
Ready?
I'm ready.
Here we go.
Okay. It gets a little redundant, but there's some stuff I want to get to at the end of the video that's great also.
Aspirate and see. Let's see if we get any bone.
I'm aspirating that blood straight up the tubing. Can you see that, Brenda?
Terrific. That does not hurt.
All right.
0, 0,
I'm coming straight up.
0.
Now they're claiming it doesn't hurt.
0. 0.
One more, that's all.
Ready?
Yep.
We're in.
Not bad, a lot of pressure.
I'm removing. I can see blood now filling up the catheter there. Okay, I'm going to stabilize her leg. I'm going to turn and lift. And here it comes. It's coming.
So the reason I'm continuing to play this is that there are some x-rays at the end where they show some injections, and you see how quickly
No, maybe a 1.
gets into the venous system.
That's it.
Yvonne, you've joined this great club. The club of people who have been drilled by the IO while awake and don't even need it.
All right. So now, see, here they're doing some injections, and you see how quickly it just gets right into the venous system. And here's a humeral injection, and there's the heart down there at the bottom. And so you can see that it quickly gets into the venous system is very effective. So in an emergency, that'd be a great way. You can see how quick they are. You can see it's a very efficient way to get a case going. Okay. All right. Now, this is the kind of thing you really don't need numbers and data for, but they have it here. If you look at how quickly you can put an I/O device in on the left versus a central line, you can see you're a lot faster putting that in. And if you have that available on your unit, you could get a case going very quickly. Also, the success on the first try, 9 out of 10 with the I/O device versus 6 out of 10 with the central line. So, it is a lot simpler and quicker way to get a case going using the intraosseous catheters. Sorry about this. Something's... Okay, got it. All right, whatever. All right. Now, there's different types of intraosseous catheters that you can use. The two on the left are these manual devices, much like when they're doing bone marrow harvests in the OR, and I've always thought that is one of the most gross operations to watch, and I don't really want to use one of these hand-operated devices where you have to provide the power. This other one on the right, that doesn't help you drive it in. It's just those spikes are just to kind of help anchor it as you push it forward. And you have to supply the force. And then you can put that in the sternum, which does have a little bit more direct route to the heart, but I don't think that's really a big issue. I haven't done a lot of this, but if I'm going to favor the devices that actually provide the power to get in. The one on the left is a spring-loaded device that you set the depth that you need it to go, either for small child, medium child, or adult. And it's kind of a spring-loaded snapping, kind of like a staple gun kind of event. Whereas I think the drill looks like the easiest and most consistent way to put these in. And the YouTube video, I think, did a good job of really showing how easy it is to put these in. Now, where they're going to go in are either, down here just to the medial side and below the tibial tuberosity, or up in the proximal part of the humerus. If you look at success rate of placing them, it's a little easier down below, but then for us, you might want to learn the humeral approach because, it's above the diaphragm, so if there are any issues with aortic cable compression or bleeding, it seems like our drugs would get to the central circulation faster using this technique, the humeral approach, as opposed to the tibial approach. But I think either one's adequate, and it's just, but I think I would choose the humeral approach. Now, some practical issues with this. Turns out that all drugs are pretty much effective and can be delivered effectively through this approach. If you look at peak plasma times, there's a little delay, like instead of like 60 seconds peak time for most drugs, it's about 90 seconds if you use the intraosseous route. A little slower, but still adequate. And all the drugs that we're interested in work pretty much the same given through this route. Adenosine has some mixed results, which, having such a short effective time, half time in the body, that makes sense that it might have a little bit of an effect by going through this route versus the IV. And there have been some reports of it, like large volume drugs given, through this can extravasate through the hole and then get into the tissues and have caused some problems. But for the large part, it's safe to transfuse things like electrolytes, head of starch, blood products, all that kind of stuff have been safely given through these devices. And notice how they were actually able to draw blood, or I guess marrow, back through the catheter as soon as they placed it. Turns out that you can use the blood for this to send to the lab to get things like electrolyte levels, hemocrit, blood gas samples, etc. And it's pretty close. It's not exactly what venous blood would be, but it's pretty close. So it does give you an idea of where you're at, so you can use it in that situation. Because of the size of the catheters are limited, the flow rates are, the fastest you can really get is about 150 mils a minute. But that's pretty good. I mean, if that's all you can get and you need access, 150 mils a minute is great. It's not like a 14 gauge catheter, but it's adequate. And there is a relatively low infection rate, and that's getting better as they learn to use these as time goes on. Now, what are some of the issues? Well, like I said, the speed of infusion is such that I wouldn't use this as my main line for a major resuscitation, we're going to talk about scenario 2 in a minute. Now, there's pain with injection. I know like they said, it was only a 2 or 3 level pain for them to place it. But the other thing is when you inject large volumes quickly, imagine bone pain like a tumor in a bone causes people a lot of pain from the stretching. Well, it's the same thing when you do the injection. So that pain, that injection causes a lot of pain as it stretches the bone. So, that would be one thing about using it for an awake patient for induction. You better hold them down when you do that first injection because, you don't want them thrashing around. And then there's also the issues with extravasation, as I talked about. One time, the back edge, the needle went through the back edge of the bone and caused compartment syndrome because they were infusing fluid into the calf, I guess, and it caused a compartment syndrome. Osteomyelitis, like I said, infections are rare, less than 1%, but the problem is the infection is osteomyelitis, which is a problem. Theoretically, there's some issues with infusing lots of fluids through the marrow that you could get like a fat embolus, issues like that. But that's more of a theoretical concern. There haven't been any practical issues with that. And then there is a little injury to the bone. If you read case reports or patient experiences with this, they might feel some pain walking up the stairs the next day or two or for a few days. But it's not a long-term issue. All right, so that's kind of intraosseous catheters. Let's go on to scenario 2. So if you remember that patient, she'd had a placenta previa with a high risk for accreta. Now this woman needs high volume lines. You don't want to go into this with the equivalent of like an 18 gauge IV. And you also may need an arterial line, and you need to get going as soon as possible before things get worse. So like I said, the intraosseous line is only going to flow about 150 mils a minute. You have a risk of extravasation when you put the line under pressure. So when you compare this to 16 and 15 gauge catheters put under 300 mils of torr pressure, and you look at the flow rates, you're much better off with the large bore IVs. And the problem, like with this woman where you don't really see veins right away, you're going to want to use ultrasound guidance, I think. If you look at, once you use ultrasound guidance for this kind of situation, you can see that you're much more likely to get in. Overall in this meta-analysis comparing ultrasound guided IV placement to just normal IV placement, you're 3 times likely to get in on the first try. And the method we use at Stanford is we have just a probe that has a maximum depth of 6 millimeters, and using a small ultrasound machine that we also can use this machine for doing cardiac echoes and neuraxial placement and tap blocks, things like that. It's nice to have that kind of machine on your unit. And when you start off, you want to look for a cross-sectional view of the vein that you're looking for. And then you get this view up at the top, if you imagine. Is this the, oh yeah. Yeah. You can see over here this round circle right there, and you get an idea of where the vein is. And then you turn it and get the longitudinal view here, and you get this view right here. And with that view, you can then, you know, this is an example of actually placing an art line, but you can actually place it under direct vision, and then you can actually see the catheter going into the vein here. And this is from Jose Carvalho's website from the University of Toronto. Now, not only are you more likely to get an IV placed with using this technique on the first try, but when you look at radial artery cannulation, it's 80% of the tries were on the first try with the ultrasound, and it's only 2% required more than 3 attempts to get in properly. And you know, also you can use the Doppler function here. You can see that you get a little bit of a pulse to make sure you're looking at an artery. The other thing, you just push on the tissue with the probe, and if the vessel doesn't deflect or doesn't squash, then that's the artery, and it's pretty easy to see. Another alternative to using a ultrasound to start large bore IVs in this situation is to put in a rapid infusion catheter. Here's a couple of them laid out, and they're pretty simple. You know, it's just like putting in a central line, but you just start a 20 gauge IV, put the wire in, and then thread these one of these catheters in, and that gives you like a 7 French introducer to transfuse through. So when you look at the you know, the relative flow rate in mils per minute, you know, it's really what you want to do is you want to get a large bore IV for sure. Here's a 16 and 14 gauge, gives you up into the 400 to 600 mil a minute possible flows. And then, of course, the 7 French, you're way up above what the speed of the Belmont fluid transfuser is going to go. And so you want some kind of access like that in this case, where you're going to have you're going to have to do rapid infusion of products probably. So hopefully this exercise has given you an idea of how to prepare for getting IV access quickly in emergencies, whether it be for large bore IV access or just really rapid access in a emergency situation. I can tell you that even just last week we had a woman coming in for a cesarean hysterectomy, and we looked at her arms, and there was absolutely no visible veins. We used the ultrasound to start a large bore IV on the first try, and we had adequate access for the case. It wasn't an emergency situation, but it's nice to even be able to place access real quickly and not be delayed. So we found that very advantageous. So I guess the question is, I'd like to ask, how many people here now would use intraosseous access in that first scenario? Okay, a few more people, that's good. All right, well, I guess it's time to get the panel up here so we can all get out and have a good Saturday night in San Francisco.